So, Zinkam An to Dr. Sim and all of her esteemed colleagues, many of whom I met yesterday. It's a fantastic team of world experts with heart and compassion working together in a multidisciplinary way with obstetrics and pediatrics working together for the sake of the patient. It's very heartwarming for me to see and to be part of this. So the focus of my career has been trying to improve the outcome of children born with congenital heart disease by improving prenatal detection of heart disease. Because as pediatric cardiologists, we know early detection can translate into improved outcomes. Of course, it's not the only step that's needed. It starts with imaging, but then, of course, we need to collaborate in a multidisciplinary fashion to achieve the best outcome for the child born with a heart defect. In many cases, that means delivering the baby at a different hospital than was otherwise planned. So the reality, this heart on the upper left, if this was what the heart always looked like, we would not be missing congenital heart disease. The problem is that most of the time, the baby looks like this. So it's, at least in my hands, it's difficult always to see the baby's heart. And I think this is the single most important reason why we miss most cases of congenital heart disease around the world. So I'm going to be talking about how to go from this to this. So, there's, of course, as pediatric cardiologists, pediatricians, we know we can detect heart disease after birth. But it's much better to detect a baby with a heart defect before birth than after birth. These are some reasons. Of course, we're already doing an ultrasound on every pregnant woman at least once during the mid-gestation. There's the small percentage of babies with heart disease that we can change the prenatal natural history. For instance, we can dilate an aortic valve, or we could treat supraventricular tachycardia. But most cases of congenital heart disease, we don't really change the prenatal natural history. We change what happens at birth and afterwards. So we can optimize where the baby is born to make sure the baby is delivered at a place where everything can be provided for that baby. Some babies with cyanotic heart disease, ductal-dependent heart disease, if you do not know the diagnosis, you may not provide the optimal treatment, such as prostaglandin. You may do something that actually can harm the baby rather than hurt the baby. And so we can initiate the appropriate management early on and avoid babies deteriorating and not doing as well as they would have with a prenatal diagnosis. So this first slide shows that babies, we can detect heart disease after birth. But one problem is that many cases of major heart disease do not present with a physical exam until after 2 or 3 days. So this is after the baby has gone home often. So even though you may think that a major heart defect can be detected early on after birth, many times even hypoplastic left heart syndrome, transposition of the great arteries, tetralogy of Fallot, pulmonary atresia, major heart disease is often missed until several days after discharge. Coarctation of the aorta and other forms of heart disease can be difficult to obtain even with pulse oximetry, which I understand is performed here. on every newborn baby before discharge, pulse oximetry to check, to screen for critical congenital heart disease. Even pulse oximetry fails to detect many forms of congenital heart disease, especially left-sided obstructions like coarctation of the aorta. So also, pulse oximetry is performed a little bit before discharge, so many of these babies can get into trouble even before that's performed. So it's much, much better to diagnose major heart disease before birth rather than after birth. This is a case that I saw recently of low-risk pregnancy at 19 weeks, had a 4-chamber view, color, no color, left ventricular outflow tract, and you could see the crossover. And this was at 19 weeks. And I'm going to come back to this case later on in my talk, this first talk. You can see if you think there's any problem or if this is normal or not, but this was felt to be normal at the time. So why are we missing congenital heart disease? Again, this is my passion. I think I've been thinking and talking about this for many years. Now that I've been standing for over 30 years, I think that the main reason, there's of course many reasons why we're missing heart disease, but I think the main reason is that it's hard to see the heart really well. I think if all of us do what we can to improve our ability to see the heart well, we will pick up many more cases of congenital heart disease. That's true in Los Angeles, that's true here in Hanoi, it's true around the world. So this is what the heart looks like. And all the clips, this is what the heart looks like when we see the heart perfectly well. And again, if we see the heart perfectly well, it's usually quite easy for those of us who have some experience to see if the heart's normal or not. This looks quite normal. But the problem is that usually, most of the time when we're scanning babies, the image is not optimal, right? Usually the image is degraded. I call it degraded acoustic windows. We can't see the heart very well. And the guidelines, most guidelines, and I'll talk about the guidelines, they assume that we can see the heart perfectly well. And so they say, well, what do we need to look to see when we see the heart perfectly well? But the problem is most of the time we face degraded acoustic windows. So I wrote this paper with some colleagues to give some idea how to improve image quality and to discuss what are the most important aspects of the heart to see, and what to do if you cannot see everything. What's the next step? Guidelines generally do not address that other than recommending maybe a follow-up scan. So first, how to optimize, how to go from this heart to this heart. This heart, any number of major heart disease can be this heart, but this rules out many forms of congenital heart disease. So the first thing to do is to choose the best probe. I like to choose the probe with the highest resolution. If you have a choice between a 4.8 or a 6.9, I like the higher resolution probe. And then if you don't have adequate penetration, you choose a lower megahertz probe. So sorry about this. you optimize the probe position on the maternal abdomen, and we did this yesterday when I was scanning, we'll do it this afternoon. When you put the probe on, the best place to see say the pulmonary valve may be here, but the best place to see the left pulmonary artery may be here, and the best place to see the aorta may be here, or the best place may be here at one point in time, but then a few seconds later it's a different. So the whole time you're scanning, you should always be moving all around it to find the best window. Always moving around to get the best window. Then optimize the maternal position, meaning if the mother, think about how the baby is lying in the mother, and if the baby is in bad position, have the mother turn on her left or turn on her right. And optimize the fetal position. If the baby is in a bad position, spine up, the head down, then have the mother go to the bathroom, walk around, get the baby to move, rather than push, 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 push in a bad position. It's better to try to get the baby to move. Then we want to optimize pressure. Sometimes people, when you're first learning, may not be pressing enough. You don't want to press too hard, but many times I found people are not pressing enough, and it makes a big difference to give a little bit more transducer pressure, as long as it's not causing too much discomfort for the mother. And then finally, we want to optimize the depth, the sector width, and the zoom, so that the heart takes up much of the picture. You want to zoom. You don't want the heart to be a very small part of the picture. We're looking at small structures. We need all the help we can get, so we make it as big as possible. So that's some ideas, many of which are review for you, but very important to optimize the image. It's very important not just to optimize the image, but to optimize the angle that we're looking at the heart. What is this that we're looking at? What is this that we're looking at? This is, in English we call it a mirage. I'm sure you think that this is water on the road, but it's not really water, it's an illusion. So how do you know if it's real, or how do you know if it's an illusion or artifact? You have to get closer to it, right? Or move your head around to look at it from a different perspective, and then the water disappears. So the same thing if you're looking at the fetal heart. Say you think that there's a ventricular septal defect. You want to make sure that you're close to the heart and that you're looking at it from the right angles. Otherwise, oftentimes they'll look like there's a VSD, and there's not really a VSD. So this is a 4-chamber view, now outflow tract, parallel to the septum. This is not a good way to evaluate the septum for VSDs or to evaluate outflow tracts. What I'm going to be talking about today, it doesn't mean you have to look at it in a different way. It's possible to diagnose ventricular septal defects or aortic override or outflow tract abnormalities when you're parallel, but it's a lot easier to do it if you're perpendicular, and you're more likely not to miss an abnormality, and you're also more likely not to think there's a problem when there really is not. So imaging, you want to do everything you can to optimize the image and the angle. So we do not want to look at the outflow tract. This is my favorite view, perpendicular to the septum. Perpendicular to the septum, with the left ventricle on the bottom, away from the probe, the right ventricle on top. And then you can see the septum in continuity with the aorta. You see the aortic valve opening and closing, left ventricle, right ventricle. This gives a lot of information from a single view, and it's worth spending a little extra time, and I'll do that, I'm sure, this afternoon, trying to get this view on every single baby. We did that yesterday on the twins, and I always try to get this view because it gives so much information. This is a normal outflow tract on the left, and here you can see it's abnormal because I've optimized the image and the angle. I'm perpendicular to the septum. You could see the VSD, the aortic override, and of course the aorta, the ascending aorta and the aortic valve are quite large compared to normal. So this is a very important view, always to try to get, ideally with the left ventricle on the bottom, using some of the tricks that I just went over. This is a view very similar. I call it my favorite view 2.0. It's very, you don't have to move much on the abdomen. You just move your wrist a little bit, and you go see, instead of the outflow, now you see the inflow. You could see the crux, the tricuspid mitral valve, and you could see the inlet septum just underneath the mitral and tricuspid valves. It's intact. There's no VSD. But this area, if you're parallel, almost always will look like a VSD. So it's very helpful to be perpendicular. So when we're thinking about the screening guidelines talk in terms of views, like the situs view, the four-chamber view, LV long axis, RV outflow tract, and the three-vessel view. It's not just, don't just think about views, think about optimizing the image and making sure you're looking with at the right angles. And maybe you want to see the four-chamber view perpendicular and parallel if you want to do color, for color flow, plus you want to do 2D. But these same concepts apply to the fetal echo. That it's, when we talk in terms of fetal echo, we don't talk in terms of views, we talk in terms of structures. But even if we're thinking about structures, pulmonary veins, mitral valve, ventricular septum, aortic valve, pulmonary arteries, and so on, it's not just did we see those structures, but did we see them well? And did we see them with the right angles? And that's something I think that we need to emphasize, that when we're teaching fetal cardiac imaging, it's not just about seeing views or seeing structures, it's seeing them well and with the right angles. So this is something I do, and you may have seen me do this yesterday with using two hands. I find it very useful to use two hands when I scan to give me, so I can hold it just right to see the heart just right and hold it where I want. And I use a foot pedal to acquire the clip. So it frees up both hands to do the scanning. I found it very useful, and a foot pedal is very easy to purchase on Amazon. It's inexpensive, and I find it extremely useful whenever I scan patients, especially patients who are difficult to scan. So there's many guidelines, of course, I'm going to talk about guidelines for screening and for fetal echo, for low-risk pregnancies and high-risk pregnancies. So low-risk pregnancies, I agree, I think the best approach, this is from ISWA, International Society of Obstetrics and OBGYN 2023 guidelines for fetal cardiac screening. And they talk in terms of 5 transverse planes through the abdomen, 4-chamber, LVOT, RVOT, and 3-vessel view. They can be done as a clip, but usually they're done 1 plane at a time. Color is recommended, but not necessarily required in this set of guidelines, whereas clips are recommended formally. And I'm going to talk to you about my thoughts about the most important elements of the guidelines for screening and for fetal echo. Here's the abdominal view, spine, descending aorta, stomach, and heart. Here's the descending of the IVC. So descending aorta, stomach and IVC, and then heart. Descending aorta, stomach and IVC, and heart. Four-chamber view, of course, I'll be talking a lot about, but you want to make sure it's the right size with the apex anterior and leftward at 45 degrees. The right side should be a little bit bigger than the left side. You should see the crux. The mitral valve, tricuspid valve should be opening and closing nicely. You should see the valves opening and closing throughout the clip, and you should always look at the distance between the descending aorta and the left atrium. I'll get to that a lot more later. And then we want to see the crux and the normal offset between the mitral and tricuspid valves. The LVOT view, again, like to optimize it, be perpendicular to the septum. Right here you can see the crossing of the left ventricular tract. We're perpendicular, we've optimized the image. You can see the aortic valve opening and closing and disappearing during systole. Always look at the aortic valve with the left ventricular outflow tract view, and you want to always look at the pulmonary valve when you're looking at the right ventricular outflow tract view. Many people don't think about the valves, the aortic and pulmonary valves very much, but you need to look at them very closely when you're doing the screening. And then the three-vessel view, of course, also you want to optimize the image. I like the spine down. And then you can go from the four-chamber view across LVOT, RVOT, and then the three-vessel view to show the aorta coming to the left of the trachea. So these are important views to obtain. They take time and practice to obtain them with high image quality and with the right angles of acquisition. But if you do that, you should not miss most forms of congenital heart disease, especially if you're able to add color. So these are elements of screening that I think are most important. To use clips, to use color flow, look in the abdomen, the four-chamber, LVOT, RVOT, and three-vessel view. And then, as I talked about, angle of acquisition and scanning techniques to optimize the image. And the guidelines, these guidelines, ISWAD 2023 and AIOM, that's the American Institute of Ultrasound Medicine in 2024, neither guideline recommends color flow or requires color flow. I think color flow should be used even in low-risk pregnancies. It takes extra training, but I think it's very valuable and should be part of the screening. The three-vessel view should be as well, but not part of the AIUM guidelines quite yet. And the angle of acquisition and scanning techniques to optimize image quality are discussed in the ISWAD guidelines, but not at all in the AIUM guidelines. Of course, there's many other guidelines around the world, but these are elements that I think are most important that should be included. What about fetal echo? This is one set of guidelines. This is the AIOM. I come from California, so we use the American Institute of Ultrasound Medicine guidelines as well as ISWAD. But these guidelines do require multiple planes, not just the transverse cuts that are required with screening, but also sagittal imaging, say of the aortic arch, ductal arch, and long and short axis views of the heart itself. Color Doppler is required. Sweeps are required, not just clips, but actually moving from one part of the heart to the next. And then cardiac biometry and spectral Doppler. And I'll talk to you about some specifics. Here's just some examples. Pulmonary and systemic venous returns. Use sagittal views of the aortic arch. You can see on the left, you can see SVC and IVC. On the right, you can see the aortic arch, and then you can see the pulmonary artery trifurcating into the right pulmonary artery, left pulmonary artery, and ductus. It's a nice view to show the aortic arch and the trifurcation of the pulmonary artery. Here's some short axis views you can see here. Short axis views at the level of the tricuspid valve, pulmonary valve, and aortic valve. It's another way to show that this is a right ventricle. How do we know this is a right ventricle? Because the tricuspid valve is far away from the pulmonary valve. And down below, short axis of the ventricles, not only to look for ventricular septal defects, but also ventricular function and size. You can see this is a right ventricle because the valve, it looks like a tricuspid valve because it's attaching to the septum. We know it's an RV. On the bottom, the valve is not attaching to the septum. We know that's a left ventricle. Pulmonary arteries, as I mentioned, we like to see the trifurcation into right and left branches plus the ductus. We don't always see that in a single plane, but when you're scanning, doing a fetal echo, you want to make sure you see all three, right pulmonary artery, left pulmonary artery, and ductus. The left pulmonary artery and the aorta, in my opinion, are the most difficult structures to see with fetal echo, so it's always important to see those really well. And the aortic arch, of course, I like to show the arch in a sagittal view because you see the head and neck vessels coming off, you can see the isthmus, and you can see where the ductus inserts. You could also look for AP collaterals and a lot of information that we get from a sagittal view that we do not get with the three vessel view. They work best when you do them together. So the guidelines for fetal echo, again, these are aspects that I consider most important. Clips, color flow, four-chamber outflows and three-vessel view, and emphasis on angle of acquisition and scanning techniques. All of these guidelines, American Society of Echo, American Institute of Ultrasound Medicine, and ISWAG, all recommend all of these except ISWAG guidelines, which are quite old and are going to be revised soon. Scanning techniques are not discussed. How do you optimize the image? That, of course, should be part of guidelines, in my opinion. This is the AIUM revised their guidelines in 2020 for fetal echo. And in 2020, they added angle of acquisition and scanning techniques, which is wonderful. But they also added cardiac biometry of all four valves, measuring how big is the mitral valve and tricuspid valve and pulmonary valve and aortic valve, and also requiring spectral Doppler across the ductus venosus, all four valves, and in a right-sided pulmonary vein and a left-sided pulmonary vein. This, of course, takes some time to do this in a reproducible way, and I think it's controversial, and certainly in my opinion, that we probably want to spend more time with other elements of fetal cardiac imaging before we do quantitative measurements of these in each patient. That is something we could discuss and get your opinions. But in my opinion, the most important techniques for fetal screening and even fetal echo are optimizing the image quality and the angle of acquisition, using color field Doppler, and using clips or even sweeps to see all the views and structures. Less important is quantitative measurements as a routine. Now, if you're suspecting an abnormality or you want to see how structures are changing over time, then of course it's very important. But you don't want to do quantitative measurements if you have not optimized the image and the angle, because the quantitative measurements will not be accurate. They may not be reproducible. And you want to, I've seen many cases where lots of quantitative measurements have been performed, but the images are very poor. And then they miss the diagnosis, even though they have lots of quantitative measurements. It happens all the time. So I think it's nice to think, well, I'm doing all these fancy quantitative measurements, I'm good, but really it's the basic imaging and the angle that I think is more important to start with, and then do quantitative measurements afterwards. So this challenging scans, when we have a challenging scan, which again is most of the time, right? Most of the time the baby is not in a good position. So if the baby is in a good position, the guidelines suggest looking at views, and fetal echo for structures. And this makes sense because if the baby is in a good position, if you get a 4-chamber view, you'll see everything really well. So you just get the view, that's okay. You don't have to worry about the structures, even for screening. But if you have challenging imaging, if the baby, you do not see the heart very well, then I do not think that we should be thinking in terms of views, like the 4-chamber view or the LVOT or the 3-vessel view. Even for screening, I think we should be thinking in terms of structures, even for screening. And that's because you may see the 4-chamber view, but if you're not thinking, am I seeing the mitral valve and the tricuspid valve well? Am I seeing the apex well? If you're not thinking structures, it's very easy to get a 4-chamber view that you're not really seeing everything that you need to see. So this is a little, I don't know how many of you like to watch birds. I like to watch birds. I watched birds out our window this morning. But if you like to watch birds, then you maybe look at this bird, and can you tell me what kind of bird this is? Some of you like to watch birds. So what kind of bird is this? So, and what are you thinking about when you're trying to decide what kind of bird it is? This happens to be a Western tanager. That's what it is. So, what's the point? What were you thinking when you were trying to decide what kind of bird? You were thinking, what does the head look, what color is the head? What color is the beak? What color is the breast? What do the feathers look like? What is the, what color is the top of the head? The views were, I wasn't thinking, I need an anterior view, or I need a lateral view, or I need a posterior view. That's not what I was thinking when I was trying to decide what kind of bird it was. I was thinking, I need those views to see the parts of the bird, to help me identify the bird, and that's how I think we should think about fetal echo. The views are not important in themselves. The views are means to seeing the structures. That's what I think we should change our mindset and be thinking about structures, not just the views. One other concept I want to talk about before I talk about a couple cases is what does fetal scanning, fetal cardiac scanning, riding a bike and writing have in common? What do they all have in common? They have in common that you can come to it, even if you come to a symposium like this, which you hopefully will learn a whole lot of information that will help you with your scanning and with your management of babies with congenital heart disease. But you cannot learn, I cannot teach you how to ride a bike by talking or by looking at YouTube videos. I can't teach you how to write by having you go to a class or a symposium. You need to start to write, or you need to get on the bike. You need to do it yourself. So scanning is something you can learn about by listening and watching YouTube videos, but you need to put the probe in your hand and practice, 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 like riding a bike, like writing. So it's important, I think, as much as you can, put your hands on the probe and learn. This is from my symposium every year. We try to do hands-on or in your own practices, just practice, practice, practice. Okay, now I want to finish up with a couple of cases of mine that I think reflect some of what I was just talking about. Okay, the first case is, these are real cases, of course. This is a pediatric cardiologist that made made a diagnosis of tetralogy of Fallot, and the patient was considering terminating a pregnancy, So they wanted an opinion. They came to me just to confirm the diagnosis and then talk to them about options and how bad it was, how bad a tetralogy of flow it was. So these are some of the images that were obtained by the initial pediatric cardiologist, showing, looks like a VSD, of course, but now you all know this is not a good way to look for a VSD, right? Or the outgoes. There are some they're measuring, and now you know this is not a good image. This is not a good place to be measuring the heart. And then here they're measuring some structure here. Many of you may know that they're measuring something above the aortic valve. I think they think it's a VSD, but it's not. Here they're doing some clips, but image quality is pretty poor. Here we're starting to do a lot of quantitative measurements, all sorts of quantitative measurements. You can see ejection time, isovolumic relaxation time, mean pressure gradients, peak gradients, E wave, A wave, ratios, lots of different quantitative measurements that they did on this heart before getting good images. And then I saw the baby and focused just on image quality and the angle. And what does it look like? What does it look like? It looks normal. So this is a baby, lots of quantitative measurements were obtained, but they did not get good images. And then they said the baby had tetralogy and the patient almost terminated the pregnancy for a normal baby. So the lessons learned are image quality, angle of acquisition, so important before we do quantitative measurement. Ascending or the dropout I'll talk about, and the perils of quantitative measurement. So here's a dropout that's very common to see this dropout above the aortic valve. This is a normal dropout. Sometimes hard to know that if you don't have really good images, so it pays to spend extra time to make sure that this is above the valve and not below the valve, in which case it cannot be a VSD. And then these are the perils or the risks of spending a lot of time on quantitative measurements before you optimize the image, because then you forget to optimize the image and you may be missing the big picture. You might see measure quantitative measurements but miss the important diagnosis. So there's a nice quote, not everything that can be counted counts. So just because you can get a K index or you can get an EA ratio or you can do this doesn't mean that it counts, that it's important. And not everything that counts can be counted. So the quality of the image and the angle, you don't really count that, but it's really important. So the last case is a case of hypoplastic right heart that I was taking care of throughout the pregnancy. So this is at 21 weeks. It looked to me, this is when I first saw the baby, I thought the baby had a small right heart. The left heart was left heart disproportion. Left heart was a little big compared to the right. But flows were normal. The ascending aorta looked a little bit big. I thought this was just related to, you have a small hypoplastic right heart, then the left side can compensate and get a little bit bigger. And then at 28 weeks, you could see how the heart's evolving. It's still, the tricuspid valve still opens well, the right ventricle squeezes well, comes to the apex, but a little bit small. And at 38 weeks, same thing. But so does anyone see anything new here? The diagnosis. Give you a hint. This mitral valve, for the pediatric cardiologists here, know that this is the best view to diagnose mitral valve prolapse. So this is a case of mitral valve prolapse with a very aneurysmal tricuspid valve. And at this point, all 4 valves were regurgitating. They were all leaking. And this turned out to be not hypoplastic right heart, which is what I was thinking, but a dilated left heart because of Marfan syndrome. So this was, we wrote this up, Dr. Sanita Nuwutnaween, MFM in Bangkok, who spent over a year with me. We retrospectively went back and did quantitative measurements to do Z-scores throughout gestation. And at this point in my career, I was not doing quantitative measurements even when I thought it was abnormal. So this is a case, the opposite of last case, this is a case where I should have done quantitative, but I didn't, and it was my fault. And retrospectively, all the right heart structures were normal, but the left heart, the aortic root, even at 22 weeks, the aortic root was a Z of over 3. Aortic valve, mitral valve, the aortic root, the Z's are over 3 throughout the gestation, whereas the right heart was all normal. Had I done Z-scores, I would have known that. I wouldn't be thinking hypoplastic right heart, I would be thinking dilated left heart. So I do think it's important to do quantitative measurements, especially when you think there's an abnormality. But first you need to optimize the image and the angle, but then when you suspect an abnormality, of course, quantitative measurements are really important. So to finish up this first talk, I'm not sure if I should click. So always optimize the image and the angle, both for 2D and color Doppler, and focus on structures, not views, especially when it's hard to see the heart. Evaluate the septum and outflows relatively perpendicular, not parallel, but relatively perpendicular. Quantitative measurements can be helpful, but only after optimizing the image and the angle. And use care when counseling the patients regarding how sure you are of the diagnosis. If you're not sure, just be honest that you're not sure. That's okay. But try to be very careful about what you tell the patient. Trust your eyes and interpret the quantitative measurements in context, meaning if you think the heart's abnormal, but the quantitative measurements are normal, probably still bring the baby back. Or vice versa. Always think about what you're seeing too. If you're not very experienced and you're not sure, then the quantitative measurements can help. And then when in doubt, or if you have very poor windows, then bring the patient back so you can scan again, or just have them see it and send them out to someone else who you think might have a better chance of seeing the heart well. So just to finish, this is case that locally was just last August. 19 weeks felt to be normal. I don't know if any of you felt that there was an abnormality here, but this was at 28 weeks, 19 weeks to 28 weeks. This is the 4-chamber view. Actually, this is the LVOT. You could barely see the aortic valve here, but here the aortic valve is very thick. This turned out to be progressive severe aortic valve stenosis with a dilated left ventricle, which evolved into hypoplastic left heart syndrome. Parents did not want to do any fetal intervention. And this was because we did not, the group who did not optimize the image of the aortic valve and the angle. They saw it, but not very well. And I think if you always focus on seeing things well, you're not going to be able to, none of us will always see everything. All of us will make mistakes and miss things. But the better your imaging and angle, the less likely you are to miss. And that's what this symposium will be. Later I've done this for 14 years at UCLA, and this will be the first year. It's now that I'm in Cedars-Sinai in April. If any of you might be able to come join us, please let me know. We'd love to have you in person, or we'll be live streaming around the world, and love to have any of you involved. Just reach out to me, Dr. Seam, and we'll help you out. So that's, this is just more about the symposium. And if people want to reach out to me, feel free to use my new email at Cedars. Xin cảm ơn.